We've covered oxidative stress. What about inflammation? That's obviously the silent killer. We've known this for many decades. And inflammation is defined by when blood vessels become like Velcro, right? We get an upregulation of adhesion molecules, the monocytes, T cells, neutrophils stick, platelet becomes aggregated, activated, clot formation, plaque instability, plaque rupture. But it's known that if we can downregulate the adhesion molecules, prevent the adherence and the migration of these immune cells, you can prevent the onset and progression of vascular disease. And this has been the problem of the spike protein that we've witnessed over the past 4 years, whether it's active COVID disease or genetic manipulation by the mRNA that now induces spike protein production by your human cells. It's the spike protein that's toxic. It binds to ACE2 receptors, allows for the aggregation of monocytes, neutrophils, platelets. These platelets aggregate, your body breaks them down, you see an increase in D-dimer levels. So everything we know about spike protein, coronavirus, long COVID, the vascular inflammation that persists long after the active infection, again, can be explained by the dysfunctional endothelium and the inability to produce nitric oxide. And in 2009, we were able to visualize this in real time. So you can see here, maybe the video will play. I'm not sure. I'm going to turn off my video just for a second. So maybe we'll get better streaming here. But what this would show, if the video would play, was that you've got microvascular dysfunction. There's a number of monocytes and neutrophils that are stuck to the lining of the blood vessel, and a number of cells have migrated through. And so we can induce this through an atherogenic diet. And so if we give nitric oxide at the same time we're inducing this vascular inflammation, it's not playing, maybe it's a streaming issue. But you can see here visually, even though the video may not be playing, the still photo shows that the blood vessel is more dilated. But what the video would show is that these monocytes and neutrophils don't stick. So we've downregulated the ACE2 receptor, VCAM, ECAM, all these adhesion molecules. And so we don't get the adhesion and we don't get the migration of the immune cells into the media, and we prevent hyperplasia, we prevent the onset and progression of cardiovascular disease. So the whole point of showing you this is that we have to restore the production of nitric oxide or give nitric oxide active compounds to prevent the vascular inflammation. And then let me change course here, because this was at a time when we were very productive in the lab. We were publishing 10 or 12 original papers a year. I was contacted by a fellow that was a cardiologist, and he was trained in traditional Chinese medicine. And he came to me and asked, Nathan, do the traditional medicines that we've been using for thousands of years in Eastern medicine, is there a nitric oxide component to those medicines that have been known to safely and effectively address a number of chronic illnesses? So you know what? That's a pretty interesting question. So Yaping came to the lab, and his first assignment was I sent him to a local acupuncture shop, and I said, bring me back the herbs you as a physician would use to treat a patient with high blood pressure, post-infarct patients, patients with heart failure, coronary artery disease. And so he brought back, 8 or 10, maybe a dozen of these herbs. And so we did it. He taught me how to do this like they do it in the pharmacies in China. So we ground these up with a mortar and pestle. We did some simple extractions. And then we put them in a nitric oxide analyzer where we could detect nitric oxide gas coming off of these herbal extracts. And you can see here the first couple of things we put in there really didn't do anything. So it's really anticlimactic. And then we start to get a nitric oxide peak here and the sustained nitric oxide release. We wash it out. We take another herb. We put it in our reactor, and we take this burst of nitric oxide. Then it comes back down, and it slowly releases nitric oxide. So if you're a medicinal chemist and you're developing nitric oxide donors, then this is exactly the pharmacokinetics you're looking for. Predictable, sustained nitric oxide release. So then I thought, well, let's do something crazy. Let's take this extract and combine it with this extract and see what happens. And when we combine these two, we could quantify the synergy that's been described for thousands of years by the ability of these two extracts to synergize and produce far more nitric oxide than it would have been with an additive effect. So these two herbs, unbeknownst to me at the time, are always used in combination because they seem to work better clinically. But yet nobody understood it. But yet this has held this test of time for thousands of years. So then we washed it out, repeated it, and we get the same exact nitric oxide release. So now we had the ability to dial in any level of nitric oxide depending upon how we mix these extracts. And then we were able to do countercurrent chromatography and extraction techniques where we identified the active components of this. But we published that in 2009, and this made Yaoping very famous in China. I went to China. I gave 8 lectures in 6 days in 7 different cities. But this was a revolution for them because we had explained mechanistically what they had seen clinically for thousands of years. So it brings scientific evidence to the traditional medicines that they've been using for thousands of years. But we thought, okay, we now understand mechanistically how these medicines are working. Can we utilize nature? Can we utilize diet and make this process better? And in order to understand this, we have to understand the atmospheric nitrogen cycle. So the air we breathe is 78% nitrogen. This nitrogen, this triple bond of the N2 is a very strong bond. So you need high energy to break this bond. And it's done primarily through lightning fixation. So we're finding now in areas of the US where there's a number of lightning storms, the soil is more enriched in nitrogen in the form of nitrate than in areas where there's less lightning storms. So any vegetables that we eat that's grown in the soil, they assimilate these nitrogen oxides, or any animals that we eat that eat the grass or the vegetables, then we're getting a source of these nitrogen oxides. So this is called nitrification or nitrogen fixing. The human body is actually denitrifying. So let me take you through this. I want to spend a little bit of time on it because I think it's very important you understand this. The mechanism of action of a plant-based diet, a Mediterranean diet, a Japanese diet can be explained by nitric oxide. So these vegetables, green leafy vegetables, are specifically enriched in nitrate. So when we consume a little bit of spinach salad here or kale or arugula, then 90 minutes after we consume that meal, the nitrate is extracted and concentrated in our salivary glands. So now after this meal, for the next 6, 8, 10 hours, we secrete nitrate in our saliva. There are bacteria that live on the crypts of the tongue, the dorsal part of the tongue, that perform this 2-electron reduction of nitrate to nitrite. And humans do not have this enzyme. So we're 100% dependent upon the oral bacteria to do this. And now, for the next 6, 8, 10 hours, our saliva is enriched in nitrite. When we swallow our own saliva, that hits the acid environment of the stomach, the pKa of nitrite is 3.4, which means at pH 3.4, 50% of nitrite becomes protonated and produces nitric oxide gas. What does that mean? If we produce nitric oxide gas in the lumen of the stomach, it's like our cardiac-specific transgenic mice. We're producing nitric oxide gas in a single biological compartment, and it leads to cytoprotection systemically. So here's the problem. There's at least 3 steps in this pathway that you have to achieve. Number one, there's a certain amount, a threshold of nitrate that we must get from our diet. We must get at least 300 to 400 milligrams per meal. And we've taken the standard American diet. We're only getting about 150 milligrams, and that's over 2 to 3 meals. So just like most Americans are deficient in magnesium and iodine and selenium and chromium from the foods we eat, we're a nitrate deficient population. We've modeled different dietary patterns. You can see here in this model here, this dotted line is the threshold of nitrate that you need to manage your blood pressure. The dietary approaches to stop hypertension and the Japanese diet are the only dietary patterns that exceed this. All of the dietary patterns fall well below this threshold. The next question was, okay, how much, if we wanted to change guidelines and make recommendations on how much broccoli, celery, or spinach would I need to eat to get this 300 to 400 milligrams of nitrate, then now we can make dietary recommendations to manage blood pressure. Makes sense. So we went, and this is in collaboration with Texas A&M. We went to Chicago, Dallas, Los Angeles, New York, and Raleigh, and we just bought vegetables off the shelf, broccoli, cabbage, celery, lettuce, spinach, brought it back to the lab, analyzed it. This is a figure from the paper we published in 2015. A lot of numbers. Let me simplify this for you. Let's take celery, the middle here. If you lived in Dallas or Los Angeles, you could go to the grocery store, buy 6 stalks of celery, eat those celery, get enough nitrate to manage your blood pressure. If you lived in New York, You have to eat about 30, 40, 50 stalks of celery. So again, this goes back to the regional differences in soil conditions, farming practices, and the variability, not just regionally, but across vegetable categories. I mean, you see here, cabbage has far less than, celery. And these are conventionally grown vegetables, vegetables that are grown in nitrogen-enriched soil. We compared this to organically grown vegetables. Organic has on average about 10 times less nitrate, 5 to 10 times less than conventionally grown. And people really don't know what organic means, right? We're conditioned to say, organic. What is organic? Well, to get an organic label in the US, no herbicides, no pesticides, which is very good, by the way, but there's restrictions on adding nitrogen-based fertilizers to the soil. Without nitrogen, without standardized nitrogen in the soil, you can't assimilate nitrate. Without assimilation of nitrate, you can't assimilate other nutrients like vitamin A, vitamin E, selenium, chromium. So organically grown vegetables are typically depleted in most of the vital nutrients, including nitrate. And then here's the other problem. Nitrate is inert in humans. We must have the bacteria in the oral cavity to metabolize this, or else we eat the nitrate in the vegetables, and if it's don't have the right bacteria, we urinate it out, we excrete it in our feces, or we sweat it out. The nitrate goes through the human body completely unchanged. We don't get a nitric oxide benefit from it. 2 out of 3 Americans wake up every morning and use mouthwash. 2 out of 3 Americans have an unsafe elevation in blood pressure. That's not coincidental. I'm going to take you through the data. There are 200 million prescriptions written for antacids every year. And now you can buy these antacids over the counter. There's Prilosec, Prevacid, Nexium. You can go and get these, and I'm going to show you the consequences of that. And then there's 200 million prescriptions written for antibiotics every year. So to me, it's no wonder why Americans are the sickest people on the planet, because number one, the food we eat is completely nutrient depleted. And then everything we do, mouthwash, antibiotics, antacids, completely shuts down nitric oxide production. PPIs, these are proton pump inhibitors. People who have been on PPIs for 3 to 5 years, higher incidence of heart attack, stroke, and Alzheimer's. These drugs were never approved by the FDA for chronic use, only acute use for esophageal reflux disease. But yet you can go to your corner store, you can buy these drugs, you can take them every day. People have been taking them for 10, 15, 20 years. And it's not only increasing, this isn't increased risk, this is actual events. 20 to 30% increase in heart attack, stroke. Proton pump inhibitors accelerate endothelial senescence by reducing telomere length. They're shutting down nitric oxide production, inactivating the telomerase enzyme, causing shorter telomeres, increasing cardiovascular, renal, neurological morbidity and mortality. And then this paper came out a couple of months ago. People who have been on PPIs for 4 years had 33% greater risk of developing dementia. Again, these are important, indisputable clinical observations based on the peer-reviewed literature. It's our job to figure out mechanistically what's happening. PPIs decrease stomach acid production, inhibit nitric oxide production in the stomach. I've shown you that pathway. PPIs increase a molecule called asymmetric dimethyl L-arginine, which is an inhibitor of the endothelial nitric oxide synthase enzyme. So PPIs completely shut down endogenous NO production, creating systemic nitric oxide deficiency, decreased circulation, increased inflammation, oxidative stress, and immune dysfunction, insulin resistance, leading to dementia and Alzheimer's, plaque instability, plaque rupture, heart attack, stroke. So there is no miracle aspects about nitric oxide. We clearly understand the mechanism. The pathways are completely well elucidated. And then what about mouthwash? This study shows that if you take normal intensive patients, you give them mouthwash twice a day for 7 days, their blood pressure goes up. Their increase in blood pressure correlates with a decrease in nitric oxide production. This, again, a very important clinical observation. How do we explain it mechanistically? We started on this path about 20 years ago. The human genome only codes about 23,000 gene products. The microbiome, the bacteria that live in and on our body, outnumber human cells 10 to 1, and they express 3 million gene products, more than 10 times of what we see, or almost 100 times more than what the human genome codes. So the bacteria that live in and on our body are there to do things that we as humans can't do. This is a true symbiotic relationship. So our thought was, can we culture these bacteria? Can we characterize them and then see an association between these oral bacteria, and blood pressure. And so this is the complete denitrification cycle. And again, humans do not have this pathway. This is only a bacterial pathway. So we did a study of people walking around the Texas Medical Center. We did tongue scrapings. We cultured the bacteria in their tongue scrapings. And here's the data we published 10 years ago. People who had the best microbiome, the more diverse microbiome, had the best blood pressure. Those that had the least diverse oral microbiome had the worst blood pressure, and there were none of these nitrate-reducing bacteria that we could culture. So this is what we call an association. It's not causation, it's association. Next, we went and we modified the IRB, and this was in collaboration with the dental school, where we only enrolled young, healthy dental students, oral hygienic students, and we gave them mouthwash twice a day for 7 days. We monitored their blood pressure. We did daily tongue scrapings. And then after 7 days, we stopped the mouthwash, allowed them to recover for 4 days. We brought them back to the clinic, and we measured their blood pressure, and we did tongue scrapings to measure their bacteria. We published this in 2019. 1 week of mouthwash use. This was a 21-year-old dental student, a vegetarian, and a triathlete. 7 days after mouthwash, we made him clinically hypertensive. His blood pressure went up 26 millimeters of mercury. We didn't change his diet. He was on no medication. All we did was destroy his oral microbiome with mouthwash. And then 4 days later, his blood pressure, fortunately for him, normalized. And we were able to detect the bacteria that disappeared when his blood pressure went up and the bacteria that reappeared when his blood pressure normalized. And we sequenced these bacteria, and you can see here they were expressing these nitric oxide producing genes. We could predict steady state blood pressure in these patients by the presence and number of these 4 different bacteria. Now this, let me spend a little bit, because this explains resistant hypertension. Resistant hypertension is a phenomenon that if you have high blood pressure, you go to your doctor, he puts you on different classes of antihypertensive medications. Typically, these are ACE inhibitors, ARBs, angiotensin receptor blockers, calcium channel antagonists, diuretics, or beta blocker, which aren't a frontline therapy for hypertension, but they're used. But yet 50% of the patients who are put on blood pressure medicine don't respond with better blood pressure. Why is that? Well, it's because it's not a renin-angiotensin problem, so ACE inhibitors, ARBs, aren't going to normalize it. It's not a disruption of calcium mobility, so calcium channel antagonists aren't going to do it. What we're finding is that the hypertension is a symptom of oral dysbiosis. So now, for the first time in the history of medicine, let's have a conversation with your patients and go, hey, are you using mouthwash? Oh, and by the way, do you use fluoride in your toothpaste? Because fluoride is an antiseptic, it's a neurotoxin, and it shuts down your thyroid function. But, and so 2 out of 3 people say, yes, I use mouthwash. 10 out of 10 people will say, yes, I use fluoride in my toothpaste. Okay, well, let's eliminate the mouthwash, get rid of fluoride, come back 30 days later, and their blood pressure is remarkably better. So no need for antihypertensive therapy. Let's give the body what it needs, remove from the body what it doesn't need. The body heals itself. So how do you improve nitric oxide production in your patients? And are there products that have been shown to increase this? So let me fast forward a little bit, because we developed product technology based on the discoveries we made in understanding endogenous nitric oxide production. So everything we do is called restorative physiology. And even our drug discovery program isn't employing pharmacology. We're not giving synthetic compounds that inhibit biochemical reactions. We're giving back a missing molecule, nitric oxide. So our whole thought process was, if your body can't produce nitric oxide, then we have to do it for you. Our products must produce this. So I developed an orally solid dose form of nitric oxide gas, the only technology in the world that delivers nitric oxide gas in a solid dose form. But we also put technology in there that recouples the NOS enzyme. And because it's an orally disintegrating tablet that spends about 5 to 6 minutes in the oral cavity, it's killing the bad bacteria and enhancing the diversity of the oral microbiome. So this lozenge provides nitric oxide if your body can't make it, and it restores the body's ability to make it on its own. We also create a fermented beet powder. Beets have been the hero vegetable for the past 10, 15, 20 years. Beets contain a lot of oxalates causing kidney stones. Beets are the 3rd least liked vegetable in the world, and 95% of the beetroot products on the market don't do anything except turn your pee and your poop red and pink and cause a lot of anxiety and make people think they're having urinary bleeds or rectal bleeds. And then I made a topical nitric oxide for skincare and for wounds. So I'm not here to promote products, but I want to inform you about which products actually produce nitric oxide, and all these other products that are marketed towards nitric oxide don't produce nitric oxide. So my line of products, if your body can't make it, we do it for you, and we fix the reason your body can't make it. But here's a short list and picture of products that are advertised as nitric oxide, but provide no nitric oxide benefit at all. And how do we know this? Because we test it. We put it in our nitric oxide analyzer. We administer these products to patients, look at the increase in potential increase in nitric oxide production. And these products are placebos. In fact, we use these as placebos in our clinical trial because that's what they are. They're great placebos. And then there's a laundry list of these. So just these, I'm not saying these products don't contain good ingredients. They're just not nitric oxide products. Some of them should be labeled as multivitamins. They're providing amino acids, some antioxidants, but these are not nitric oxide products. They're trying to give your body the precursors or substrates to make nitric oxide, but the underlying problem is that you've lost the ability to convert these into nitric oxide. We're never deficient in these ingredients. We've lost the ability to convert it. So let me just make 3 points here. Beets do not equal nitrate. I've measured probably every beet product on the market. 95% of them contain no detectable nitrate or nitrite. Nitrate is not nitric oxide because we have to metabolize this by the oral bacteria. So if you're using mouthwash, it doesn't work. If you're on antibiotics, it doesn't work. If you're on PPIs, it doesn't work. And then arginine and citrulline products do not work in patients with endothelial dysfunction. So what to look for? Is there evidence the product works? Does it produce actual nitric oxide? Are there published clinical trials on the actual product? And has the inventor formulated or published original research on endobiochemistry? Do a PubMed search. There are a lot of companies out there who have these talking heads who've never spent a second in a research lab, wouldn't even know what a research lab looks like, but they're the talking heads for these products who have no idea about nitric oxide. So don't be fooled by creative marketing. Science and experience matter. Nitrate is like giving T4 to a patient with hypothyroidism. T4 or synthroid is inactive enzyme. It has to be converted into active T3 or T2. But again, this is dependent upon the thyroreducting enzyme, depends upon iodine availability. So again, nitrate is inactive. You must have the ability to produce it. So plant-based, potassium nitrate-based products only work in about 1/3 of Americans due to simple lifestyle. Again, there's companies out there trying to sell you capsules, beet capsules. Well, let's just do the simple math. We need 300, 400 milligrams of nitrate to see changes. Beet powders, at best, are 9% nitrate. So that requires at least 3,500 to 6,000 milligrams of beet powder in a serving. And yet they're trying to convince you that you can get in a single capsule, which is 600 or 700 milligrams at best, enough beet powder to contain enough nitrate to manage blood pressure and generate nitric oxide. This is a game. So the math doesn't work. The science isn't there. You cannot deliver 3 to 6 grams of beetroot powder in a capsule or a gummy. Now there's companies out there putting grapeseed extract, resveratrol, acetylcholine, all these activators or stimulators in gummies, which basically is just a sugar matrix. Again, this requires a functional NOS. And if I wanted to take a seed and plant it in my garden, a corn, for example, or vegetable, and I soak that seed in kerosene and then put it in the soil, is it going to yield any fruit? Of course not. Same with grapeseed extract. You put grapeseed extract in a gummy, you glycate that ingredient, and you basically inactivate it. It's like you'd be just as good putting in kerosene and then taking it. And gummies, look, the last thing Americans need is more sugar. Sugar destroys the oral microbiome, leading to loss of nitric oxide production. Sugar glycates the NOS enzyme, causing it to become dysfunctional. So nitric oxide cannot be delivered in a gummy or a chew. In fact, it decreases nitric oxide production. So turn off your TV. Don't buy the gimmicks, the fraudulent, deceptive marketing used by a lot of these companies trying to convince you that you can get nitric oxide in gummies or chews. Again, what we do is completely different. We base product technology based on overcoming the deficiencies of endogenous systems. And let me take you through very quickly the clinical trials from product technology I've developed over the past 10 to 15 years, then we'll open it up for questions. This nitric oxide lozenge, you put it in your mouth, it produces nitric oxide. This is the same nitric oxide analyzer we use to test the traditional medicines, generates nitric oxide, we can quantify it, we can detect it. It's vasoactive. You can see lowers blood pressure within 20 minutes, both systolic and diastolic pressures. 60 minutes later, further reduction in blood pressure long after that lozenge is gone. 4 hours later, we've recoupled the NOS enzyme, 15% improvement in endothelial function. If you take a picture of the carotid artery with an ultrasound, you get baseline pictures here, you give the lozenge. We've increased the diameter of the carotid by 13%. That's a 34% increase in blood flow. Now, if you take that SPECT scan I showed you at the very beginning, now you increase blood flow to the brain by 34%. You think that patient's going to get better? Of course. And this is showing plaque regression. This is using the lozenge twice a day for 6 months. We see 11% plaque regression. Not only can we, if we catch this early on, prevent the onset and progression of that disease, but we can actually see reversal. And then let me just end with this study here at Texas Children's Hospital. In pediatric disease, there's an inborn error metabolism. These kids are born without an enzyme called arginosuccinate lyase. And this is what we call the partial urea cycle that's present in every cell in the human body. And so as you can see here, this enzyme ASL converts arginosuccinate into arginine. But when these patients are born without this enzyme, they get a buildup of arginosuccinic acid. They excrete it in the urine. It's called arginosuccinic acid urea, or ASA is what we call it. So these kids develop hyperammonemia, and they'll develop liver dysfunction and cirrhosis. Many of these kids will have to get liver transplants at very early age, or they'll die of liver failure. But even though they're managed with diet and drug therapy for their hyperammonemia, they still develop systemic disease, blood clotting disorders, resistant hypertension, kidney disease, neurological dysfunction that's independent of their current hyperammonemia. So these physicians came to me in 2007 to try to understand this disease. And what we did, we modeled this in the lab. We created an ASL deficient mice, and we published this in Nature Medicine in 2011. And what we discovered was this ASL enzyme is what tethers the nitric oxide enzyme to the membrane. And so when these patients are born without ASL, this protein complex falls apart, and now they've lost the ability to produce nitric oxide. And when you look at this clinically through the nitric oxide lens, a nitric oxide deficiency explains all these symptoms and collateral symptoms that they present with, the blood clotting disorders. Nitric oxide prevents platelet aggregation. If you can't make nitric oxide, platelets become hyperactive. Nitric oxide is a major vasodilator. If you can't make nitric oxide, you develop hypertension. You start spilling protein and you get renal hypertension, spilling protein into the urine. So we thought, can we intervene in these patients? So this is a lifelong blood pressure profile of a single ASA patient. You can see here that for 10 years was very poorly managed, put on polypharmacy. And in February of 2010, he came to Texas Children's Hospital. His blood pressure was 210 over 115 in the intensive care unit. Nothing would lower his blood pressure. So we started giving him isosorbide, which 4 days later, these organic nitrates that produce nitric oxide. His blood pressure managed, released from the hospital. And he came back. And as I mentioned earlier, patients develop tolerance to these drugs. So he came back to Texas Children's a year later, taking 20 milligrams isordil 4 times a day. Blood pressure was 185 over 110. We dosed him with our lozenge. 4 hours later, his blood pressure completely normalized. We got him off all prescription medication. His kidney disease resolved within 5 days. When we started him on the lozenge, his kidney disease resolved. His heart disease, when we saw him, he had a heart twice the size of a normal 15-year-old. 5 months later, normal cardiac function, normal cardiac size. We mobilized his own stem cells and completely remodeled his heart. So the nitric oxide that we delivered through this lozenge completely rescued a kid with an inborn error metabolism, a genetic disorder. That shows you the power of nitric oxide and giving this molecule. So obviously, these patients are given 20 to 30 grams of L-arginine per day because they can't make it. But yet again, arginine deficiency, even in these patients, isn't the problem. It's restoring the function of the enzyme, and it's giving an exogenous source of nitric oxide that otherwise they couldn't make. And to affect public kind of policy and public health, you don't even have to be that good at lowering blood pressure. A simple 5 millimeter reduction reduces the risk of stroke by 34% and ischemic heart disease by 21%. Now, let me take you very quickly through how, we focused on nitric oxide, but I don't want to take away from the broader kind of subject matter here and how you can integrate all this into really transforming patients' lives. This guy here is my dad. Dad turned 76 this year, but he's been rolling around in a wheelchair since 1984. He had an automobile accident, a T11 injury, so mid-back down, complete paraplegic. And so Dad used to evacuate through digital stimulation. Years and decades of doing this, developed a severe hemorrhoids. We had hemorrhoidectomy surgery. And his surgeon told him to go sit on a heating pad 30 minutes, 3 times a day to facilitate healing. And when you do this to a paraplegic diabetic, you cook him, unbeknownst to him, because he doesn't have any feeling. So obviously, this led to full thickness, third-degree burns on his backside, severe risk of infection. This is a clinically, severe condition here. And so we took him to Brooke Army Medical Center. The surgeons there said Dad probably wouldn't survive this injury because of his comorbidities and his age and paraplegia. And so I took this picture right after the skin graft. So they took a skin graft from his inner thigh. And so obviously, being paraplegic diabetic, there's poor blood flow here. So I created a nitric oxide topical to get blood flow to this graft so we could heal this wound. And we did an ostomy to divert the waste material into a bag to prevent the infection. So the surgeon said it would probably take if he survived this, by the way, it would take 9 to 10 months for it to completely heal. This was 2.5 months later. We completely healed this full thickness, third-degree burn simply by giving topical nitric oxide, improving the graft, improving the healing process. So this was a major win. But when we graft over the burn, he had developed a full thickness ischial ulcer. So this is under his right butt cheek here. I could put a tennis ball in this wound, osteomyelitis, osteonecrosis. Dad was septic, almost died. But when we got him out of the hospital, 10 days of IV antibiotics, again, we started employing these basic principles. Topical nitric oxide. I did ozone insufflation into this wound to try to kill the infection and to oxygenate the wound. But every wound care doc I took that to said we would never heal this wound. This is a non-healing wound. 4 years non-healing, we started to employ these strategies. This is today. We completely healed a 4-year-old non-healing wound simply by employing these strategies. What we do? Dad had severe dental infections, root canals, metal in his mouth. We took him and had restorative dentistry done, IV ozone insufflation, red light therapy, topical nitric oxide. We took his fat, spun down his fat, isolated the stem cells, injected the stem cells into the wound, around the wound, got about 90% growth, and then we closed it with a surgical flap. So this just goes to show you that if you employ these simple strategies, and again, nitric oxide is foundational, but it wasn't a silver bullet. We still had to employ these other strategies. Then, if topical nitric oxide can do that to a wound, what can this do to one of the largest organs, the skin? So I created a commercial nitric oxide delivery system, and I'll take you very quickly through the clinical trials here. This is using the topical nitric oxide twice a day for 30 days. You can see here the age spots disappear, the inflammation on the chin, inflammation here on the neck. This is a 52-year-old lady. Tone, texture, clarity of the skin improved. The broken blood vessels, a 50-year-old Hispanic male, varicosity. Tone, texture, and clarity improved. A wound here, a lady who had a facelift who started smoking and applying pressure here before the skin had a chance to fully reattach. Full thickness ulcer. The surgeon applied the serum 3 times a day. 10 days later, got complete closure. Polycystic acne, the topical nitric oxide kills the bacteria in the pustules, completely mitigates the inflammation, and complete resolution of polycystic acne in 30 days. This lady had a 15-year-old scar from teenage acne, and using the serum twice a day for 30 days, again, you can see almost complete remodeling, sloughing off the old cells, bringing on new cells, completely remodeling the skin. This is a smear of Pseudomonas, which is a bacterial infection found in most non-healing ulcers. The nitric oxide completely eradicates the infectious bacteria. Here's some of our clinical data from our topical drug. 4-year-old non-healing diabetic foot ulcer we heal in 30 days. 2nd-degree burn, 21 days, no scar formation, complete healing. And then Yale Medical Center contacted us. They had a 64-year-old paraplegic, 4-year-old non-healing wound. Started applying the topical nitric oxide. We completely healed this 4-year-old wound in 195 days. And to date, we haven't seen a wound that we haven't been able to heal with nitric oxide. So let me just wrap up here, because what we try to do is recapitulate nature. And I think that's the intent of medicine. Medicine early on was applied physiology. Today it's applied pharmacology. We have to get back to physiology, restorative physiology. So this little guy here is Lincoln, who's now my 16-year-old. But when he was born, we were released from the hospital. The discharge nurse told us we should breastfeed, but if we can't breastfeed, give the baby the formula. So when we left the hospital, I kidnapped my wife and I brought her to my lab and I collected some of her breast milk. And then I compared it to the formula we were sent home with and just put it in my HPLC, and I quantified the nitrite and nitrate. So the breast milk, which was now colostrum, contained really high levels of inorganic nitrite, non-detectable in the formula. So then I went to the IRB in the labor and delivery unit of Memorial Hermann in the medical center, and we collected breast milk at different stages postpartum, and then we analyzed it. And what we found was colostrum was enriched in nitrite. As this milk transitioned into mature milk, nitrite went down, nitrate went up. And then we collected serially over 3 to 4 patients from the same donor over a period of time. And again, the colostrum was enriched in nitrite, and then once after 3 to 4 days, or about a week, it shut down nitrite expression in the breast milk and converted it to nitrate. And when you think about this, why is this? Well, babies are born sterile. They don't have an oral microbiome. They don't have a gut microbiome. So nature exquisitely concentrates nitrite in the breast milk, in the colostrum, because you don't need bacteria to utilize nitrite to make nitric oxide. But when you allow the colonization to occur, the breast milk then switches and provides nitrate to allow for the diversification of the microbiome, both in the mouth and in the gut, and then the body can make it on its own. And now we found out this is different in cesarean versus vaginal delivered babies. We can completely rescue necrotizing enterocolitis, still a 20% infant mortality, simply by giving nitrite in the formula. The other example came from people living in Tibet, 12,000 feet above sea level. If we go to Tibet, we develop mountain sickness, high altitude pulmonary edema, and people die all day, every day trying to ascend because they can't acclimate. So the question was, how do people who live at 12,000 feet above sea level operate? What is their adaptive response to low oxygen? And that's a very important question, because low oxygen can be environmental or it can be pathological, ischemic heart disease, COPD, emphysema. So we compared the people in Tibet to people that live in the US, primarily Houston and Cleveland, at the Cleveland Clinic. So even though these people that live in Tibet are breathing in less oxygen per inspiration because the partial pressure of oxygen is much lower at altitude, they deliver more oxygen per unit time. We collect the blood of these Tibetans, and they're producing about 50 to 100 times more nitric oxide than we do in the US. So the adaptation to breathing in low oxygen is an upregulation of their capacity to produce nitric oxide. And we published this in the Proceedings of the National Academy of Science in 2007. And now this explains altitude training. Olympic athletes go to Colorado or Mexico City or altitude to train because they upregulate their nitric oxide production, improve mitochondrial efficiency, improve mitochondrial biogenesis. So now when they come back down to sea level, they're a well-oiled machine. So it's not about altitude training inducing hematocrit and hematopoiesis. That's part of it. The adaptive effects to altitude training are through an upregulation and increase in nitric oxide production. So let me just wrap up here with kind of some take-home messages, because people ask me all the time, how do I improve nitric oxide? Well, you got to do 2 things. Stop doing the things that disrupt it and start doing the things that promote it. If you use mouthwash, you have to stop. Mouthwash kills the microbiome, causes an increase in blood pressure. You lose the protective benefits of exercise, and fluoride does the same thing. So buy a non-fluorinated toothpaste, buy a house filtration system, because fluoride's in most municipal water supplies. Get rid of mouthwash, get rid of fluoride. And stop using antacids. I mean, the data are very clear. These drugs are causing increased death from heart attack, stroke, and Alzheimer's. There's nothing good about antacids. Your body cannot and will not heal without stomach acid production. Stop eating sugar. Sugar's a toxin. Get rid of gummies. Don't get your nutrients in gummies. It causes glycation of the enzyme, develop endothelial dysfunction. Now, if you stop mouthwash, stop fluoride, stop eating sugar, now you've actually released the brakes on nitric oxide, and your body can actually produce it. Throw in some more green leafy vegetables, 20, 30 minutes of moderate physical exercise a day, infrared light therapy or just sunlight exposure 20, 30 minutes a day. And if you don't want to do that, then we have products that do it for you. And I show you this because this is a paper I published 20 years ago. And the point of this was that if we're making nitric oxide, we need to be able to control and dictate the metabolic fate of nitric oxide, because there's some reactive nitrogen species that you want to avoid. And if you don't know what you're doing and you push nitric oxide at an incompatible flux rate, then you can form these nitrosating agents. So these companies and these products out there who don't understand biochemistry and physical chemistry of nitric oxide can do more harm than good. Some of this is just naivety, but some of it, these companies are out there outright deceiving you and causing fraud because they know better, but yet they're putting profits before safety. So the greatest enemy of knowledge is not ignorance. It's the illusion of knowledge. You know, ignorance is curable, and I think that's why we're all here today, because ignorance is just a lack of information and knowledge. As we learn more through science and innovations and discoveries, ignorance becomes curable. Stupidity is something we can't deal with because it's the ignoring the knowledge and information and not applying that. And it's the greatest enemy of knowledge. So I just conclude that nitric oxide controls and regulates blood flow and oxygen delivery. The older we get, the less we make. That's responsible for cardiovascular risk and chronic disease. As I mentioned, diet and exercise are not always sufficient, especially if you're using mouthwash, fluoride, or antacids. Strategies to restore NO production will no doubt change the landscape of medicine and change the world. But we must use safe and effective nitric oxide product technology. Your body cannot and will not heal without it. And I think, I haven't made very many friends because these companies who are selling so-called nitric oxide products, I call them out. And to me, it's dangerous because it could kill an entire industry, because I hear people all the time saying, Nathan, you talk about nitric oxide, but I've been taking a nitric oxide product for 10 years and it doesn't do anything, doesn't make me better. So nitric oxide must not be that important. No, nitric oxide is extremely potent. It's extremely important. What you've been doing is being subject to deceptive marketing and fraudulent advertising. You're taking a product that doesn't produce nitric oxide. So there must be accountability in the science. These companies must be held accountable because it can kill an entire industry. In fact, an industry that will change the landscape of medicine. And again, I like this quote. These are quotes that have stood the test of time. What we've discovered are fundamental truths based on biochemistry and physiology. But these truths go through 3 stages. First, they're ridiculed. Secondly, they're violently opposed. And third, they're accepted as being self-evident. And certainly I've experienced all of these through my professional and adult career. I've been ridiculed by my academic colleagues. I'm being violently opposed now. I'm subject to a number of lawsuits from companies who don't like what we're doing, trying to shut down what we're doing because it's disruptive. If you're doing things that don't matter, people leave you alone. So I wear this as a badge of courage because what we're doing is disruptive and it will be violently opposed. But I'm patient enough to know the third stage is right around the corner. This will be accepted as being self-evident.